Hello, good afternoon. Thank you, Beth, for that. And I want to also just very quickly, you're going to hear a lot of thanks today, but thank you, Tom, Neetu, Beth, and Derek. I think, yes, hi, Derek, for your patience and guidance as I've dipped my toes in the more academic side of nursing. Real quickly, thank you to Dr. Kinney and Dr. Sharma, who were so generous with their time today to educate us on their research. And lastly, thank you to a man who resists praise vehemently, the king of ECMO himself, Dr. Greg Soreo, because if without his kindness and mentorship, I would not be up here today. So with all of that said, thank you for bearing with me there. Again, my name is Molly Sullivan, and I have been at Sinai for 6 years. I started off in the emergency department, worked there for 3 years before transitioning to the cardiac ICU or CCU. And so we are a unit which takes care of a wide array of critically ill patients, but we specialize in those suffering from severe cardiac illness, be it acute or chronic. And as we've seen today, we have a lot of patient overlap with and collaborate very frequently with our next door neighbors in the cath lab, who, by the way, have also taught me so much today, so thank you for that. So today I want to talk to you about a type of higher level of life support that the sickest patients in the CCU might require, and that's called mechanical circulatory support. So I'll talk to you today about what that is, but more importantly, how indispensable nurses are in making any of this safe or possible. So hopefully by the end of this talk, you'll be able to explain how a nurse can promote the functionality and safety of a mechanical circulatory support device itself. You're going to hear me call that MCS. Hopefully you'll be able to recall at least 2 areas of interest while performing a physical exam on one of these patients. And lastly, hopefully you can begin to start evaluating how nurses promote the optimal recovery from a more holistic perspective of patients on MCS. So I'll structure this first. I'll go over the mechanical circulatory support devices themselves, so we're all on the same page. And I really want to hone in on the role of the nurse here with a 3-pronged approach, starting with our care of the pump or the device itself. I want to talk about our care of the patient. And lastly, I want to talk about our care of the person. So that is the human being lying in the hospital bed who so often gets lost in these discussions. So I'll quickly start with the devices. And here is is it going? There we go. Here's the most frequently seen device in CCU. It's called the intra-aortic balloon pump. And on the left, you have a good visual of what you might see walking into the room, and that would be parked at the foot of the bed. And on the right is a great visual of what this actually looks like in relation to the patient and the connection points. So how this works is a very interesting device with 2 parts here. We have an arterial catheter that's advanced into the position anatomically that you see on the left, and it has an elongated balloon at the end, and this catheter is connected to the pump, which, using the patient's native cardiac cycle, is able to very carefully time inflation, deflation of that balloon. And so at the very start of diastole, this balloon will inflate, and this sudden rise in pressure is able to push the column of blood above it backwards, where it then can flow into the coronary arteries and perfuse the heart muscle itself, or myocardium. You can imagine that in a weak or shocky heart that this would be of tremendous value. It then will deflate at the very start of systole, first of all, to let blood move past it and get to the rest of the body, but this also can provide some afterload reduction, and that alone can facilitate the left ventricular unloading, or LV unloading, and that in turn can decrease the oxygen requirements of the myocardium. So the effects of both inflation and deflation here work very synergistically together to provide quite a lot of support to patients in cardiogenic shock. Also quickly add here that one of the main advantages of this device, just other than just being more straightforward to use than the other 2, is that we can place this emergently at the bedside. And so you can imagine if a patient is decompensating and it's becoming clear that they need more support. It's of tremendous value to us that we do not have to account for the time and human resources in getting them on a cath table to place it there. We can do it right at the bedside. Next is probably the least commonly seen device in CCU, but according to Dr. Sharma, maybe we'll be seeing it more. So this is called the Impella. It's a pretty unique device, not to be underestimated. And essentially this is, it's inserted similarly to the balloon pump, but this is actually advanced all the way into the heart, terminating in the left ventricle. And because of that positioning, this does require fluoroscopy to place safely, and that means for us that we do not place this in the CCU. So we do have to collaborate with our friends next door in the cath lab if a patient is going to require this level or type of support. And there we go. And lastly is the highest level of support we offer, which is called ECMO, or extracorporeal membrane oxygenation. So this device is amazing in that it is able to support the heart through its pumping mechanism, but it also contains an oxygenator, which enables it to unburden some of the workload of the lungs as this patient is recovering from severe illness. A great advantage of this is that we can, like a balloon pump, place this emergently at the bedside, and you can imagine for the sickest patients how useful that would be. And there's actually a growing area of research and practice where ECMO is inserted during an active cardiac arrest with ACLS underway, and we call this ECPR. And once the patient is fully cannulated and flows are established on the device, we can actually hold compressions because ECMO is taking over the responsibility of perfusing the patient, and will do a far better job than we can with our hands. So this is what ECMO actually looks like. And so on the left is a great visual on, it looks like a femoral or groin site on an ECMO patient. This is what we would most see in terms of site in CCU. You see two large cannula. The darker one has the upper one has darker venous blood, which is draining deoxygenated blood from the patient, and it sends it to the oxygenator. So unfortunately, you can't see that in this photo here, but this you would see at the foot, parked at the foot of the bed. And in this oxygenator, gas exchange can take place. So it's able to actually oxygenate that patient's blood, remove carbon dioxide, and then the pumping mechanism of this device is able to deliver all of that blood back to the patient. So obviously, nurses are not the ones that are inserting these devices, nor do we prescribe their settings. However, I want to make clear here how indispensable we are in making sure that any of this is safe and possible. And so I'll transition to the discussion about care of the pump. And I'm going to start here with a brief little talk on environmental safety, which almost sounds trivial, but at least in my almost 9 years of being a nurse, I have found that most medical errors, minor to major, can really be traced back to a ball having been dropped on something very fundamental, and this is one of those things. This is what I'm talking about. So these are among the sickest patients in the hospital, and they have a lot going on in these rooms, and so it requires, I guess, almost a mastermind or architect to situate this room in such a way that not only can we have streamlined and safe workflow, but that all of the equipment in the room is able to function. We also have the widest breadth of knowledge about every device here. And specifically with MCS, we're constantly ensuring that we have reliable power supply to these life-sustaining devices, and that everything is situated in such a way that nothing will get yanked or pulled on, which, as you can imagine, with large cannula like an ECMO, that's very important. So I'm going to discuss now our role in anticoagulating these patients. So anytime you introduce a foreign surface into the body, the natural reaction will be to clot around it. This is a problem for us because if a clot forms in or around that device internally, then that can really impede the functionality. So we must offset this risk by thinning the blood, and we track our progress in this regard through trending a lab called APTT. We essentially use that as a surrogate for blood thinness. We accomplish this through the use of continuous IV anticoagulants. We're phasing out heparin, which most people are familiar with, and starting to use a drug called Angiomax. And if you're familiar with the nurse-driven heparin titration protocols, we use similar ones for Angiomax, and those protocols actually involved one of our CCU nurses. I want to add here, too, that we exercise a unique level of autonomy in managing these medications because, at least in the CCU, we as nurses are the ones ordering and scheduling the APTT draws, tracking the results, adjusting the doses, so definitely a higher level of autonomy here. However, I have to mention that anytime you thin the blood, you increase the risk of bleeding, which can open a whole other host of problems that we are constantly vigilant in watching for. So I think this is a good place to now switch our discussion to the care of the patient and most appropriately their neurological status. So sorry, this button is getting a little sticky. There we go. So again, we have both increased risk of both clotting and blood thinning, and that too applies to the brain. So increased risk of both types of stroke, the results of which can be devastating, and if the neurological prognosis is grim enough, it can render all of our efforts futile. I want to add here too that neurological assessments on any patient are probably the most technically challenging. There's always some degree of subjectivity, but these patients are very sick and many are not able to participate meaningfully in our neurological exams, and so we are often limited in the amount of information that we can glean from assessing them. That is coupled with the fact that these assessment findings are very high stakes. Even a subtle change, if missed, can be a sign of something devastating looming. And I want to re-emphasize our role here in terms of just the broader organization, because like any other patient, if we are to suspect a stroke, we would most likely just go to CT. But let's revisit what that looks like. And so you can imagine if most or all of the equipment that you see in this room has to go to CT, the CT table is the easiest part. It's actually coordinating a team of different personnel for their respective devices, and even just fitting in an elevator is a tremendous logistical challenge, and with any movement, it's just rife for hazard in terms of safety risk for the patient. So nurses really are the ringleaders, the captains, who organize a team to make sure that this is a streamlined, smooth process with good communication. Next, I want to talk about our role in assessing perfusion, because that is, let's see, sorry, this is, there we go. Okay, it's getting a little sticky, but sorry. The goal of all mechanical circulatory support is to improve perfusion, and so that is to the organs, to the extremities, and again, I want to emphasize to the brain. So throughout our shift, we'll be performing repeated vascular assessments, the schedule of which will just depend on the patient. So we are checking to make sure that blood is getting to the whole body while they're on this therapy, and also assessing particularly around the hot spots of these device insertion points. We're looking for signs of bleeding internally, for clotting, and signs that blood is not getting to distal tissues and causing ischemic injury. More on that in a moment. Additionally, many of these patients are fresh out of cath lab, and so they're going to have multiple points of vascular access that we have to account for in our assessments. So I want to emphasize here that all three devices are inserted into arteries, and particularly as the devices provide more support, the size of that dwelling within the artery becomes larger, and that means that we're increasing the risk as well of blood being unable to flow distal or past that insertion point, and that can lead to limb ischemia, which in the CCU is really in one of the legs. And this can turn into a pretty hairy complication and prove to be a very significant obstacle in what is already a very challenging illness to overcome for the patient. And sorry. Whoop. It's very, wait, hold on. Oh man, I missed the really good part for you guys. Okay, so for ECMO in particular, we often use what's called a distal perfusion catheter, and so that's the thinner catheter you see below the main ECMO line, and this is to prevent the limb ischemia. So what this is doing is it's redirecting some of the oxygenated blood flow from the ECMO and delivering it as a separate private blood supply just to that leg to make sure that we don't have any distal limb ischemia developing, and the results can be very dramatic. Unfortunately, I kind of spoiled this, but this is a good visual of before and after, just to show you what an impact that has. However, I do want to take this time to emphasize that the patient's descent into looking like that top photo is often a process which is far more gradual and subtle than this side-by-side would lead you to believe. And so it really does take savvy and good instincts on the part of the nurse to catch ischemic changes early, so that hopefully we do not develop any actual injuries, and hopefully we don't ever look like that top leg. So lastly, I want to touch on the nursing care of the person. And I think that especially as our patients become more complex and have a higher acuity, so too does our tendency to conflate their personhood for patienthood, for room number, for device type. And it's built into our medical language, including the language I'm using today. And nurses have the unique privilege of being the most front-facing members of the healthcare team, and therefore we're afforded the most opportunities to help humanize our patients, make sure that they feel seen and heard as people, that their goals and wishes are made clear to the team. And this is, one of the most central parts of being a nurse is being that support system. However, it's very difficult to quantify how important that is, let alone put on a PowerPoint slide. So I'll shift gears to two things I really can discuss metrics-wise that will promote the chances of this patient being able to discharge home, hopefully whole in one piece, and able to go home and live a life which is meaningful to them and most closely resembles to that they lived before they got sick. And the first part of this is our role in mobilizing these patients. So as you can imagine, it can be a significant challenge. However, we all know that getting patients out of bed and moving improves outcomes across the board. So there are many barriers in terms of safely mobilizing these patients. Even small movement can lead to bleeding at the insertion sites. We have to be very mindful of the bending and twisting motions involved in mobilizing that could potentially compromise the patency or flow within the device insertion site. Fortunately, we have dedicated physical therapists who bring to our unit a lot of background and experience with this population specifically. So I think that between their talents and background and our work as CCU nurses, I think that we form a very effective team in making sure that we can accomplish both of our aims here, which is first to get them out of bed and B, keep them safe. So lastly, I'll touch just briefly on skin integrity. So these are sick patients. We got prolonged immobilization, but I want to just take a look at a visual here. So you can imagine looking at the patient on the right, how many different points of contact between the patient's skin and equipment. And on the left, you see an injury just simply caused by a urinary catheter. So you can imagine all of the injuries that could be lurking underneath this life-sustaining equipment. Nurses throughout the shift will be very busy handling everything I've talked about and much more, and so it takes a level of meticulousness on the part of the nurse here to make sure that injuries like this are never events. So key takeaways. I hope that you're able to see that nurses play an indispensable role in ensuring that the safety and efficacy of these devices and their use at Mount Sinai. Hopefully, sorry, there we go. Okay. Hopefully the clinical expertise is very obvious to you now in terms of how of CCU nurses, that it directly improves patient outcomes. And lastly, I hope I've been able to make clear that the quality of life for the people, both during and after being on MCS, is made possible by meticulous nursing care. So I hope I've done justice to the work that my incredible nurse colleagues do every day in the CCU, as well as justice to the people to whom we render this care. And on the topic of people, you may or may not have seen that this talk was prepared in memory of my first ECMO patient, who I'll call Miss JW today. And I met Miss JW on October 15th of 2019 in the emergency department here, and sadly she passed away that same day. She was, however, cannulated on ECMO first, and so I can tell you 6 years later that I can remember so clearly that it was with great awe and wonder that I first saw what this is and the lengths that we can go to save people's lives. She sadly is not here today to hear how hard we work to save her, so thank you for listening for her.